Joining us on the panel is our own Dr. Mithya Lewis-Newby, and she's an attending physician in cardiac intensive care here at Seattle Children's Hospital. She's also assistant professor of pediatrics at the University of Washington School of Medicine, and she's also part of our faculty at Truman Katz Center for Pediatric Bioethics. Her area of expertise and her interest in ethics is in pediatric critical care, particularly surrounding some of the ethical issues related to ECMO, and we're happy to have her join us. So I have a lot of questions, but I know we've already got people lined up, so I'll go ahead and start over here. Questions for the panel?
Thank you for some great talks, by the way. Francis Degnan, University of Northern Iowa. This question, actually, it's a comment question about the first talk. I've run into something where I've seen, at least where I live, in terms of gaming the system around Plan B. You know, corporations, they don't want to get, well, actually, unless you're chick-a-flick, you don't want to get involved in controversies. And so, so Plan B is sometimes seen as controversial by corporations. So what happens in this one pharmacy is a woman goes and she asks for Plan B, and they say, sure, we'll provide it, but we don't carry it because there's no demand. So we'll get it for you tomorrow. The result is the woman goes someplace else because, of course, it becomes less effective as time goes on, and then the pharmacy continues to claim, oh, there's been no demand. And that's their way of avoiding taking sides and avoiding carrying it. Have you run into this problem, and what do you suggest about it?
Thank you.
Actually, is the mic on?
Should be on, yeah.
It's the first time I heard of that, although I must say, given my bent for cynicism, I'm not surprised. I mean, I think it's clearly not in the spirit, letter, or whatever of conscientious objection, which is to clearly state your reasons, your objection, and you know, openly, publicly, transparently deal with it. So I think it's from an ethical perspective, it's one of these, I think, very simple cases where you can say that's just absolutely inappropriate.
Do others have thoughts on this case before? Just to follow up on that, I did have one question about that case. With certain patients, like the one that you mentioned in your example of the rape victim, is it ever the case that the clinician's moral judgment to refrain from providing treatment sort of adds insult to injury, in the sense that she may feel that you're judging her need of the contraception?
I think that's a very good observation, and I think one of the constraints on communicating one's objection is to not insult patients, to make sure that it's a respectful treatment of the patient. So to give patients a moral lecture would definitely be inappropriate. It would be incompatible with the obligation to respect one's patient, to respect persons. So it has to be done in a very respectful way, has to be done in a way where it's stressing that the individual is not able to do something. And probably the best way to do it would be to say something like, there's someone else who I want you to see who can give you more information about options that are available to you. And that would be the most neutral way of not even communicating, there's something that's so bad I can't do it. It's just there's somebody, it's like you refer somebody to a specialist. So this would be a specialist in informing about this particular procedure that the person objects to.
Did others of you want to comment on that before you?
I think about this in the critical care setting too, where moral objection, moral discomfort, moral distress grows over time, and you can have a series of providers that are morally uncomfortable with providing whatever therapy it is. And over time, I think that those experiences of the healthcare providers are perceived by the families, and that can cause additional distress. And I think potentially one of the answers is to continue to find guidelines for helping providers deal with their moral distress, similar to what Cynda has proposed, and providing guidelines for clinicians to be able to excuse themselves from providing treatment for that family, that doesn't put the burden of their moral distress onto the family. So I think that's an important component of all of this.
Dr. Rushton, did you want to add anything or no? Okay.
I think she covered it.
Okay, thanks. We'll get to the middle.
Sure. Jerry Milstein, I actually am a curmudgeon from Children's Hospital, and I'm coming after Doug. And Doug, I look at
Since he's our curmudgeon, that's good.
So the rest of you can rest. Maybe not. The point I'm going to make is that no head injury is acceptable. And as Doug knows, I've treated head injuries almost all of my career. And I even warn parents when they come in when their kid has a headache as a consequence of a football injury, and they say, well, when can he go back to play football? And they know very well, maybe they don't know, but they do after they see me, the word is never. And the point of accepting a small percentage of head injuries in any circumstance that is preventable is not acceptable to me. And what I advocate is that we should be more proactive in looking at other activities. And so they say, well, what sport can he participate? And I said, any sport in which there's a net between you and your opponent, or swimming, or track. But I don't think we are strong enough advocates for looking for alternative forms of energy expenditure in youth. And just allowing him to do it, not that we're giving him permission because we're sitting on the sideline and, quote, protecting him. Let me tell you about inconsequential head injuries that usually occur in football because we have helmets. Well, recently I had a conversation with Rich Ellenbogen, who is the chairman of the National Football Head Injury Program. And I said, Rich, do helmets protect against concussion? And the answer is no. The only thing they protect you against is fractures. And so any kind of jarring of the brain within the skull has the potential, if not the actuality, of producing an injury. And why do you want to waste a good, talented person on a football field or in a boxing ring or any sport in which there's that kind of contact? So we need to be stronger advocates for getting them out of those activities and encouraging other activities. Your turn, Doug.
So what I would say, Jerry, is you're absolutely completely wrong. You're not coming after me at all. There's nothing you said that I disagree with, and I think it's all consistent with mostly consistent with what I just said. There may be a little bit of a difference of opinion about covering these events. What I do think is there is inconsistency in having a policy against amateur youth boxing when you don't have a policy against other contact sports that have equally risky outcomes. And that's a debate that we don't have time to have about how strong, because you're not just talking about football anymore, you're talking about basketball and soccer and lots of other very popular sports. And obviously one of the sort of things you have to consider when you start talking about advocating against any of those sports is whether what youth get out of participating in those sports cannot be justified by the risk. And again, that's probably a debate we can't have. But everything you've said, I think, is still sort of consistent with what I said, which was that I think you can advocate against these things, but still in some cases remain open to covering these events if there is some benefit to the participants in having you there to do so. And I think the argument I've really tried to make is that there's not an inconsistency when you do that. I mean, I disagree that sort of is tacit approval of those events. I think it's really just pragmatic. I mean, it's the fact that I can advocate against these until I'm blue in the face. I can, do what I need to do to get the schools to maybe change the rules and make them safer and all of those sorts of things. But the bottom line is, as long as there are kids participating in those events, they are better served if somebody trained is covering those events who can actually intervene in exactly the same way you did in your clinic, which is to say, you've had a significant concussion here, and I don't care what your coach thinks, you should not be back out on the football field the rest of this season. And as long as I'm covering this event, you are not going back out on the football field. I mean, if there's anything that healthcare providers need, I think it's the courage to be able to do that. And unfortunately, what you sometimes see is that professionals who cover events become a little bit too cozy with the sporting end of the event as opposed to the medical end, and start sort of talking to the coach about, well, is it really necessary? We should be stronger about that. But the only way we can actually even play that role is to be there.
Dr. Rushton.
I think one of the other aspects of this that's really important is for us to consider what is the amount of effort that is necessary to fulfill our obligations in our professional roles. So for example, we cannot guarantee a particular outcome of our efforts. So is it discharging our moral obligation to identify the problem, to take steps to address it, to use sufficient effort to bring awareness to the problem, to be engaged in all varieties of mechanisms to try to increase the protection of children in this case? So at some point, there's, I think, a need to accept the situation as it is and to recognize what our responsibility is to take action and have the courage to take action to address the issue. But at some point, we have to decide what is sufficient effort, and how do we then view our own efforts, not in a way that ends up being self-deprecating and negative toward ourselves, but actually acknowledges that many people in this room take a whole variety of actions to try to address some of these systemic issues as well as individual issues involving patients and families.
Just go ahead.
And I just wanted to, my specialty is critical care, so I'm going to bring it to critical care also. But another analogy, and I see a lot of people from critical care here, is that patient at the bedside. And again, there's a perception of inappropriate medical technology to keep this child alive. And it's not necessarily the most appropriate setting to disagree with the family about their choices of care, but that some other avenues might be to, again, advocate on a national or institutional level to look at professional norms and change professional norms. Those might be other avenues that you can work in as well.
Just wanted to note that the kind of the non-participation argument, I think would require, or at least the counter to that, which is, well, it's going on anyway, and so I'm going to participate in it, and I'm going to make it as clean and as non-harmful as possible. I think that is an acceptable approach within certain constraints. But if the activity is demonstrably really harmful, or really, let me use that E word, evil, then that, I think, has crossed the line. You can say, well, it's going to go on anyway, and I'm just better at doing this. I torture better than other people. I execute less painfully than other people. So there are some limits, and I think the main thing, as Doug is pointing out here, is probably reasonable people can disagree about the harm-benefit ratio here, and it might be a situation where you could say, both individual parents and individual practitioners have some discretion to make that judgment.
Thank you. Ben?
Yeah, I have a question for the panel, but it's inspired by Mark's talk and your case two. And it's also a question for Mark too, because I was surprised at your selection of case two, in contrast to one of the previous cases that you said was not about conscientious objection, which had to do with the issue of the feeding tube for PVS, because I think that paradigm is perhaps the one in pediatrics. Versions of that paradigm are the ones that people most often associate either with conscientious objection or moral distress, which is some sort of medical intervention, such as the G-tube, such as a tracheostomy, in some child with some profound degree of disability. So I'm curious why you didn't choose that one, and then also what other people think of how they would approach that case in this framework.
Well, and that actually gives me an opportunity to comment a little bit on Doug's cases, because I think the primary reason I didn't focus on that sort of situation, Ben, is because I would characterize that or classify that as an objection that's based on at least perceived norms of professional integrity, where that's a situation where no practitioner ought to be engaged in that enterprise because further treatment is not benefiting the patient, and the profession the goal of the profession is to provide medical care that can be expected to benefit. And similarly, in the boxing case, the claim, at least, that Doug was addressing is not an individual clinician's claim that, well, I can't participate in that kind of activity, but it was a claim about the profession of pediatrics, that since the goal of pediatrics is to promote the health of children, pediatricians generally should not be participating in this activity because this activity is in fact making children less healthy rather than more healthy. So that objection then is really saying it would be wrong for pediatricians to do it because this is contrary to the norms, the professional norms, the goals of pediatrics. And similarly with the ICU case, the claim is that it's just inappropriate to provide medical care in this kind of situation. It's not that I personally am morally opposed to it, but I think that this just goes beyond the limits of what kind of care ought to be offered to patients, right? And so that's why I didn't put it, I wanted to get a case because I think the context for it's a source of moral distress, to be sure, but the context for conscientious objection, at least as I understand it, is taking the model of military service. There's an activity that is viewed as being appropriate. In case of military activity, it's military service, it's an obligation, and the individual is seeking some sort of release from doing that service, even though other people are legitimately doing it. And that's what I think kind of is the core notion of conscientious objection.
So I'm sure that we're probably going to say something similar, and that is I'm not sure that your claim that providing care for a neurologically devastated patient who's not brain dead in the intensive care unit is a standard of professional practice, that is not in any way beneficial. I think there's a diversity of opinion on that, and I think that most of the ICUs that I'm familiar with would view a decision to continue life-sustaining therapies or discontinue them as morally permissible. So I think that part of this case makes it more difficult to just sort of claim that on the grounds of conscience that one might excuse yourself from that, one's role in that. I would be more interested in trying to understand on what basis that you said that was in your talk, that exploration on what basis one would claim that I want to be excused from participating in this patient's care. So it leads us into the territory of what kinds of things would count. Certainly there are people based on their own religious views that might actually view the provision of medically provided hydration and nutrition as part of a sanctity of life argument. And that to participate in that might actually violate a person's core values about who they are and how they see themselves and how they want to be in relationship to actions that lead to death. But it's also very common that part of what is being activated is that sense of moral distress, that people are recognizing from their own viewpoint that this is not an action that I would personally choose myself. Then how do we understand what our professional obligations are? And I would say that that's where engaging in activities that help us to really clarify and stabilize our own emotional responses to the situation can be really helpful for someone to discern whether or not in those rare instances where a person feels perhaps that the moral distress is of a magnitude that it's causing them personal harm, that may also be a reason why someone might say, you know, I understand that a parent can make this choice. It is not congruent with my own personal values, and it is also the case that I'm experiencing so much moral distress that it's beginning to affect my own personal well-being. I think we have to take those claims seriously as well, because if we don't, then we're not creating an environment of integrity and respect for everyone in the circumstance. And we have to think about, what do we owe each other in community? What do we owe each other in terms of a group of people who work in an intensive care unit? Would it be acceptable for me to say, I'm really struggling with providing care in this case. I need some relief, and I'm going to ask my colleagues to support me by relieving me of my assignment, with the understanding that in our sense of community with one another, that we would expect that the other person would also provide that relief if requested, as a sense of solidarity and support of one another, rather than creating this situation where, you know, you sort of throw down the trump card and I'm not doing it, which often has reverberations that are usually not really helpful in the end, both to the patient, to the team, and to the family.
Mithya, did you want to add to that?
I don't have much to add to that. That was fabulous. But yeah, but just in the critical care setting, I mean, I think that there is, the idea of professional norms and boundaries is extremely unclear. We're at the edges of medical practice. We're dealing with death and dying, which is very value-laden, and we lack a lot of professional boundary. We have a lot of professional boundaries, but the boundaries of medical care are unclear. So we're frequently acting in that scenario. And I think, again, we just have to be clear about the degree of moral harm we feel that we are being exposed to or sustaining in dealing with those cases, and try to separate out whether we feel that overall professional norms should be changed, or whether in this particular instance with this particular individual in this family we are sustaining moral harm and need to somehow be removed from the case. And but I echo everything Cynda said.
I think we have time for just one more question. Yes, please.
Thank you. Thank you. Those are wonderful discussions. They're very thought-provoking, but I would make the observation that almost everything you've said would really be applicable to the adult world also. We all struggle with adults making choices that are harmful. There's an additional layer when we're talking about children. I'm a child abuse doctor, so one of the things that we struggle with is when parents are making choices for children, we struggle with issues of autonomy and respect for persons because there is an additional layer. And I think that's one of the real moral distresses in the pediatric world when we're dealing with parents. And again, we as professionals who have devoted our lives to children begin to struggle with the choices they're making. Even the issues, it's not just parents choosing, adults choose bad things, we respect it and we try to figure out how to help them. But now you have parents making choices that are affecting. So I just wanted that additional layer there. And do we have some little more moral responsibility as professionals because there are children and sometimes parents not necessarily always acting in their children's best interest?
Thank you.
Well, I think the answer to your second question is yes. And I mean, that falls into at least two categories. The first is we have an obligation to try to, when we really think parents are on the wrong track, to educate them and get them back on the right track, which is what I'm advocating we do with families who won't immunize their kids. But the second is that when we actually see a parent who's placing a child at significant risk of serious harm, we have an obligation to try to intervene. And the way you do that in at least the United States is you involve Child Protective Services. And the cases I presented were, they both involve issues where it doesn't cross that line. And that's sort of where the moral distress starts, right? I mean, these are situations where you really don't have grounds for making a claim of child neglect or child abuse. It doesn't reach that threshold. But boy, you've still got a parent who's doing something you don't think is best for their child. And, you know, quite frankly, the tool that's left with healthcare professionals is persuasion at that point. And so that's what you want to optimize. The more coercive approach with the immunization issue is to fire them. But the problem with firing them is you lose the best tool in your toolbox, which is persuasion at that point. And who knows where they're going to go for care now? Somebody who actually, you know, are they going to go to Jenny McCarthy's pediatrician who thinks vaccines are bad? I mean, you can make things worse that way.
I just have to say one thing about this issue, particularly around child abuse and neglect. As Doug points out, often the system that was created for a particular purpose has been exhausted and overwhelmed. And so there's a system that needs reform. In the meantime, we're left with struggling with how to deal with these cases that don't clearly meet the criteria for neglect or abuse. And it is a place where I think we experience profound moral distress. And it's partly related to our sense of helplessness and powerlessness to change a system. It's also related to our sense of accountability. Have we done enough? And what are the limits of doing enough? Where does that threshold? And I think this is a place where we need to actually take actions ourselves in individual families, not only for persuasion, but to look at, are there other safeguards that we could bring to bear to help this child to have a safe passage through their childhood? Are there other resources that could be brought to bear? And what is our responsibility at a public policy and advocacy level to discharge our responsibilities to these children, you know, to affect those system reforms either locally, regionally, or nationally?
Thank you for that. And I just wanted to underscore, since it's an issue close to my heart, I think sometimes moral distress and moral dilemma should be distressing. And that part of the emotion, our emotional response, moral outrage is sometimes appropriate, and it can be, you know, lead to an impetus for action, and that can also be empowering for those of us that are distressed by it. I want to thank everyone, and please join me in thanking the panel and this morning's speakers.